Hello. So today the topic is going to be eneuresis or bedwetting. It's a very common condition and it is a self-limiting condition. Though it is self-limiting, it is seen that there is a significant emotional stress on both child and parents when there is a eneuresis, especially the nocturnal eneuresis. The parents think the child is doing it intentionally, but actually the child faces social embarrassment, shame, low esteem, because in front of the younger siblings he or she is pointed out guilty for bedwetting, and the parents of these eneuresis children are very frustrated. So it strains the parent and child relationship. Many times it is a very helpless situation for the family. So today we'll see what is the different types of eneuresis and then how it can be managed and then what medicines are available for these children. Starting with the definition, eneuresis means repeated urinary incontinence or involuntary passing of urine in clothes or bed beyond the age 5 years, when the bladder control should be established. Less than 5 years, it is very natural a child is passing urine in bed, but beyond that age this is not correct. So to diagnose eneuresis, the diagnostic threshold will be when eneuresis occurs 2 times per week for 3 consecutive months. So every week 2 times the child is passing, and consecutively 3 months if the child is passing and the child is equal to or more than 5 years, then you can term this condition as eneuresis. The different types of eneuresis. Number 1, monosymptomatic type. So monosymptomatic type, there is no urinary symptoms or bladder dysfunction, and this is of 2 types, primary and secondary. We'll deal about these conditions in the next slides. Then another type is non-monosymptomatic. Here there is association with lower urinary tract symptoms like weak stream, daytime incontinence, there might be hesitancy, reluctant to pass urine, and then post-micturition dribbling can be there, and there can be urgency, very urge to pass urine. Now classifications, the different types. Primary nocturnal eneuresis and secondary nocturnal eneuresis. There are 2 types. It is said primary nocturnal eneuresis when the child was never dry at night or never developed a dry condition at night. So this type of eneuresis occurs in 90% of cases, and boys male to female ratio is 3:1, much higher in the boys than the girls. And secondary nocturnal eneuresis is the child becomes dry at night for at least 6 or more than 6 months, then again starts passing urine in the bed. So that is then relapse. Often this is related to some stressful situations or infections, certain emotional stress like someone dying in the family or a younger sibling being born, or suppose the school is changed, the environment is changed for the child, or there is death of somebody. So this sort of especially the mother, so this sort of conditions will lead to eneuresis. So this is known as secondary eneuresis. So when you take a history, you have to differentiate whether this is a primary or secondary, which is very important. Then third type is known as nocturnal eneuresis. That is when a child is passing urine during sleep hours, that is at night, bedwetting. Diurnal eneuresis means when there is wetting during the daytime, and this is more commonly seen in the girls, female child, and it is mainly related to the micturition deferral. This is not going to pass urine until in the late time. The urinary bladder is full, but the child is not passing urine and then when it is late time she cannot control, so she passes in the clothings. And this type of enuresis settles by 9 years. And there is another type known as combined enuresis, that is both daytime and nighttime the child is wetting the clothings. So if the child is having a combined enuresis, this suggests urinary tract abnormalities. So this type of child requires a detailed investigation. Now come to prevalence of enuresis. Boys at 5 years 7%, girls at 5 years 3%. So it is seen more in the male child than in the female child. Boys at 10 years it decreases and becomes 3%, and girls at 10 years 2%. So gradually by age it is spontaneously resolving. Then it is seen there is a high genetic predisposition. If one parent is having a primary nocturnal enuresis, then the chances of that child having enuresis is 40%. If both parents had primary nocturnal enuresis in their childhood, then in their child 75% of the cases will have nocturnal enuresis. Now come to causes or etiology. Etiology is multifactorial. Maximum cause is non-organic, and then very less limited it can be organic also. So non-organic conditions like sleep disorder. Some children, they have a deep sleep pattern, so they sleep so deep they don't realize passing the urine. Another is genetic predisposition, we just saw in the previous slide. If there is a family history of parents having nocturnal enuresis, there is a high chance for the child also to have a nocturnal enuresis. Another is psychological stress like emotional triggers or any family maladjustment, disharmony in the family environment. And the emotional stress, we already said, there can be change of some environment or death of some near close ones. Small bladder capacity, so this is by development they are going to improve. So limited functional urine storage is there, so there is a nocturnal enuresis. 15% cases is associated with a constipation, so you have to always take a history of constipation when the child comes with a nocturnal enuresis. Reduced nocturnal ADS secretion is a natural phenomenon in the younger age group, so that time they will have nocturnal enuresis, one of the common cause for the primary nocturnal enuresis. Then late toilet training. Actually the toilet training for a child should start by 12 to 18 months. You should start the toilet training, but in our culture many times we see 3-4 year old child also, they do not have a toilet training, proper toilet training. So this leads to enuresis. Etiology. Now the organic causes. Less than 3% cases may have organic conditions like urinary bladder irritability, which can be due to urinary tract infection, severe constipation, obstructive uropathies. So obstructive uropathies means if there is a stone anywhere leading to obstruction, or any valves, or any posterior valve or pelviuretic junction obstruction, those are the anatomical abnormalities. If those are there, it creates irritable bladder irritability leading to enuresis. Neurological delay like delayed sphincter control, that is developmental, and then spinal cord abnormalities and mental retardation. If the child is mentally retarded, there might be some neurological problem in the bladder also, so that leads to nocturnal enuresis. And some conditions of polyuria like diabetes mellitus, diabetes insipidus, in both there is a polyuria, so that will be again another cause for enuresis. So here the child is passing in morning and daytime and night both. So this is a pathological condition. Some main primary causes for primary enuresis and secondary enuresis. So primary enuresis main causes will be delay in bladder maturation or that development of the bladder, reduced nocturnal ADS secretion, this is a physiological phenomenon, and some baby children having deep sleep pattern and genetic predisposition. And some main causes for secondary enuresis is emotional stress like trauma, school, which occurs in the school environment or family environment. And then it can be constipation, it can be due to urinary tract infection, diabetes mellitus, diabetes insipidus. These are more commonly, the organic causes are more commonly seen in the secondary enuresis. So when you take a history, you have to differentiate whether this is a primary or secondary enuresis, because it is going to help you for further investigation and management. Now, investigations of enuresis. Urine analysis, you do urine routine microscopy and culture sensitivity to see if the child is having a urinary tract infection. You may have to see the urine osmolality or urinary glucose, because there might be diabetes insipidus or diabetes mellitus. So diabetes insipidus osmolality is decreased. And then voiding frequency chart you can do. So here normal is passing urine 4 to 7 times in daytime is normal, and abnormal is if they are passing more than 8 times or at less than 2 hours interval. The frequency is less than 2 hours interval, then this is considered abnormal. So to see whether this is a normal or abnormal, you can do this chart. Another is imaging studies are required if you suspect some pathological conditions. So dorsal lumbar spine is done to see if there are any spinal defects. X-ray is also going to show you spinal defects or any stone, renal stone or calculi anywhere in the urinary tract. That is the obstructive uropathy. Ultrasonogram also for obstructive uropathy, and MCU mainly done for the posterior urethral valve or vesicoureteral reflux. For this, some investigation can be done. And blood glucose is done for screening the diabetes mellitus. I forgot to mention, in causes, vesicoureteral reflux VUR is one cause for enuresis. Now come to the treatment approach, which is very, very important, because you have to teach how to handle the child. Starting the treatment is after 7 years. We say this because this is a very highly spontaneous resolution condition, because there is a high spontaneous cure rate. By 7 years they go into remission. So after 7 years, after with the behavioral therapy also, if the child is not improving, then you have to start medication. So this age 7 years is usually meant for starting medication. Usually we go with the non-drug treatment. 60 to 70% success is seen with the non-drug treatment. Here we include reassurance to the parents that this is a very benign condition and it is going to resolve. And we teach motivational and behavioral therapy for the child and teach the mother how to take care of this child or how to control those. So the points for the behavioral or motivational therapy is: number 1, no evening fluid. So you will not give any fluid or any liquid after the PM, after the dinner or after 6 PM usually. We recommend no fluid to the child. So strictly the mother should stick to this and the child should also understand. And void before bedtime. So before going to sleep, the child should void. And then wake up to void 2 to 3 hours after sleep. So if child sleeps, so before the parents sleep, they can wake up the child and then make the child void and then again go to sleep. And another very important and very successful point is using the reward or star charts. This gives more than 85% success. So this star chart, you use a calendar or notebook and you can teach the child himself or herself also. They can do it by themselves. That is more effective. So here the child is going to plot the dry nights. So child will make a aim that this week I will not pass urine at night for 3 times. So that sort of aim they can make, and then if they reach that target, you should reward that child. So this way it is seen, by this way there is a high success in curing the enuresis. Another is urinary bladder training is important. So here what the child does is, daytime the child drinks water, lot of water, and then when the child is wanting to void, he holds the urine as long as possible during the daytime. So initially he starts holding the urine for 2 minutes, then 5 minutes, then 10 minutes. So that way he goes on increasing the time until he can hold the urine for half an hour. So if they do this, their sphincter becomes stronger, so they can hold the urine. Another is when they go to pass urine, they should practice start, stop, start, stream. So they will start the stream and stop, again start the stream. So this way they will practice the exercise while passing the urine. So this the child should be doing, so child should understand. So after 7 years or 5 years, after 5 years they understand, so you can teach them to do this, and the mother can follow them and then help them to do this. And another point is, you can avoid caffeine intake in the evening, or caffeine intake as a whole they can reduce, because it has some diuretic effect. So try to exclude this, like caffeine containing drinks will be coca, soft drinks, chocolates, all these things they can decrease, or they can stop taking all these things. Another effective measure is enuresis alarm device, so which is not available in our setup, but some developed countries they can use enuresis alarm device. So the success rate with this is 50 to 70%. So here use the alarms which trigger at voiding starts. So as soon as the child starts voiding, the alarm is vibrated or the sound comes and the child awakes, gets up and then passes urine. So this is very, very helpful also. So with all those non-pharmacological measures, if the child is not improving, you can use the medicines, or pharmacotherapy is given, and this medicine is indicated for more than 7 years old children. So number 1 drug which is used is desmopressin acetate, also known shortly as DDAVP. So this can be given orally, or there is a nasal spray for this, and the mechanism of action is it decreases the nocturnal urine production, so at night they will not pass urine. So this medicine you give for 3 to 6 months, success rate is 40 to 60%, but the bad thing is there is a high relapse rate after tapering. Soon after you stop the drug medicine, the child will again start the nocturnal enuresis. So it's better you treat the child with a behavioral therapy. That takes a longer time, but that is better option. Second drug we use is oxybutynin, that is an anticholinergic drug. This reduces the bladder contraction and then helps the passing of urine. And this drug is used if DDAVP fails, or many times DDAVP is not available and oxybutynin is available. So in that scenario also you can use this. And this treatment also lasts for 3 to 6 months at least duration you can give. Again scenario is same, if you stop there is a relapse. And third drug you can use is imipramine or tricyclic acetate. This alters the sleep arousal pattern and success rate is 30 to 60%. And this is reserved as a third line drug because of its side effects. There is more of the side effects, so this is used as a third line drug. If these two drugs are not helping, then you can use this. Like a prognosis of enuresis, most of the children outgrow enuresis naturally with age. So this is a very benign condition, and the annual spontaneous resolution rate is around 15%. Thank you. So very important what the family needs to know. They need to know that it is a very common and condition and it resolves spontaneously as child grows, and it is not the child's fault. This is an involuntary condition, child is not doing it voluntarily. So you have to tell the parents it is not the child's fault, because many times they blame the child, they think child is doing it intentionally. And number 3 is they punish the children. So avoid punishment. This is third point they should know, because if you give punishment, it worsens the condition. So you should not punish them. And very important is just have patience. Patience and then just support. This is a key point to help the child. So parents should be very supportive and very patient so that the child improves. Okay, thank you. Next class I'll deal with eneuresis, that is a passing of stool in inappropriate areas.